We are so excited to have another pelvic floor talk. These are different professionals speaking about the pelvic floor, so I'm so glad some of you are back, as well as some new faces. So today we have Dr. Pashinsky and are you a doctor, Staci? Yeah, Dr. Levine. Okay, I just wanted to make sure I was announcing you correctly. And Dr. Pashinsky is a board-certified gastroenterologist who completed her medical education and training at Mount Sinai. Within gastroenterology, she specializes in women's gastrointestinal health with a focus on the pelvic floor. I'm so sorry. Her interests also include colon cancer prevention and general gastroenterology. And Dr. Staci Levine completed her doctorate training at Columbia and is the director of pelvic health at Zion Physical Therapy. She is passionate about women's health and restoration of pelvic function postpartum as well as post-operatively. And she is certified to treat gynecological, bowel, and bladder dysfunction as well as orthopedic injuries. So, with that said, I'm going to hand it over to both of you. Thank you so much for taking the time to speak with us today.
Thank you guys for having us, and thank you, amazing, brilliant, inspiring ladies for joining us. And it sounds like we have some big shoes to fill since we're getting such good feedback about the last session. We were trying to catch it, but they don't have the recording ready yet. So we wanted to make sure we're not redundant, but I think there's always sometimes repetition does help. And I think this session, Staci, do you want to share your screen so we could start? Staci's going to share her screen. She's going to be, we couldn't be in the same place at the same time. So Staci's going to be advancing slides for me and then for herself.
Okay.
So basically, this is going to be a little bit about getting to know your pelvic floor. And Staci, we go to the next one. The main objectives for our talk today is to have you guys understand all the basics of the pelvic floor anatomy and function, what the purpose is, any problems that could arise, particularly as it relates to, gynecological and oncological treatment, and how they might present for different patients, as well as all the different diagnoses that a pelvic PT could really be super helpful with, what one would expect during such an evaluation, and what different approaches might be implemented for your care, as well as kind of some of the medical approaches that I might be able to offer. So first we'll have Staci tell us all about pelvic floor anatomy, and so we could all understand a little more.
Yes. Okay. So the pelvic floor really is just a group of muscles. It sits in the bony pelvis, which connects to the lower extremities, your hips, your spine, and is an integral part of the core four musculature. So what's the core four musculature? The core four is your diaphragm, which kind of sits at the top of your rib cage, the pelvic floor at the bottom of your pelvis, your transverse abdominis muscle, which is kind of this broad, flat muscle in the lower part of your abdomen, and some of the muscles in your back, which all need to work synergistically in order to really create full function of the urinary system, the bowel system, the sexual system, and also your core as it relates to strength and function when you do really any activities of daily living, return to activity, sport, tennis, whatever it is that you want to get back to. You really need everything to work synergistically in your favor and be strong and flexible. So I have my little pelvic model here. I can't see myself, so just let me know if you can't see the model of what I'm showing. This is
perfect. Thank you.
Okay, great. This is the pelvis. This is a female pelvis. This is looking at the pelvis from the front. You have your pubic bone in the front, which is kind of that hard bony part right in the front of your lower abdomen. You have in the back, you have the lower part of your spine. You have your sacrum, which is this triangular bone, and you have the tailbone, which is right here. You also have your ilium, ischium, and pubis, which make up your hip bones that kind of sit laterally. Everything you see in white is bone. Everything you see in red is the pelvic floor musculature. So you can see there are superficial muscles, which is that layer 1 muscle that surround the urethral opening, the vaginal opening, and the rectal opening. These are the ones that are more superficial. Layer 2 is the urogenital diaphragm. And a lot of times you don't need to know the names of these muscles, but just knowing that they're involved in both sexual, bowel, and bladder function is important. Layer 2 is located a little bit more internally and kind of rests right around the urethra. Layer 3, or what we call the pelvic diaphragm, is made up of the levator ani, the pubococcygeus, iliococcygeus, coccygeus muscles. Again, names are not important, but just knowing that those are the muscles that sit a little bit deeper into the pelvis that are, again, involved in sexual, bowel, and bladder function. The pelvic diaphragm boundaries, just like I was naming before, the pubic bone in the front, the ischiopubis ramus in the ilium, and then the sacrum, coccyx, and piriformis in the back. You also have all of your gluteal muscles that are very closely interrelated to the pelvic floor. So in a lot of what you'll see that we talk about later is we are also addressing all of the muscles of the core and the pelvis and the low back, because they so closely relate to the pelvic floor and really have an interplay with the actual pelvic floor muscles. So now that we know where they're located, what are their functions? Again, it's a group of muscles housed within the bony pelvis that form a sling and function to provide what we call the 5 S's. So it's easy to remember. Support, they provide support to the pelvic organs. So it's a group of muscles, but you also have your bladder, your rectum, your uterus, your intestines, everything kind of sits and rests on top of the pelvic floor. And if you have weakness in the pelvic floor or laxity in the connective tissue, that's when you potentially have an issue of a pelvic organ prolapse. They are sphincteric in nature, which means that they control the opening of the bladder and the rectal openings to allow urination and defecation, and they also contract to prevent leakage. They are very involved in the stability of the core, and they're an integral part of those 4 muscle groups that we were talking about: the abdominals, the hips, the back, and the pelvic floor. They are sexual in function in that they help to achieve and maintain erections, but they also need to relax and stretch and allow for penetration and be strong enough to elicit an orgasm. And they also act as a sump pump. So this is a way in which they act where they basically pump lymph and blood from the pelvis. And dysfunction in this can lead to swelling or congestion in the pelvis. So this, we'll get into how it relates specifically to oncology function later, but if there are lymph nodes removed from the pelvis, this can definitely be an issue, specifically for this patient population, because you are missing this pump that is allowing the fluid to be pumped back into your system.
So, tying into what Staci just described, we could see that essentially all gynecological cancers will involve your pelvic floor clearly, right? So whether it's ovarian, uterine, endometrial, cervical, or vaginal cancers, they all involve these muscles. And unfortunately, the life-saving necessary treatments that you guys have bravely undergone, they definitely leave their mark. And as minimally invasive and advanced as surgical techniques have become, they definitely leave scar tissue no matter how you slice it. Obviously, you end up having a loss of, whole areas, right? So the middle compartment where the uterus is kind of, you now have sort of an empty space that was previously taken up, and the support tissues that goes along with it. It could also damage some of the issues related to vascular supply and sort of disrupting some of this musculature. Chemotherapy obviously targets all rapidly regenerating cells. Those would be very much the cells of your gut, as well as the vaginal mucosa, so interplaying in that. And pelvic radiation necessary, can cause a tremendous amount of scarring, and inflammation of the mucosa as well. Staci, can we advance a little bit? Next one, yeah. So when the pelvic floor is not functioning as it should, you could see that multiple levels of dysfunction can happen, and this actually applies to males and females. It's not a female-specific thing, but clearly today we have a female-specific population. You need to be able to coordinate, and this requires contraction and relaxation. And when there's any level of dysfunction or damage, you end up having dysfunction among the 3 compartments, which could lead to bowel dysfunction, bladder dysfunction, obviously sexual dysfunction, and pelvic pain and pain in general. So next slide, Staci. Right. So the most important thing that, very important thing we want you guys to take away from this is that the more information that your doctor has, whether it's your GYN, your gastroenterologist, your urologist, or your oncologist, the more this advocates for you to get the care that you need for this. And it's what to sort of bring up and what to monitor in yourself doctor's visit, because all of these things are massively affecting the quality of life of cancer survivors. And you shouldn't be settling for just saying, well, your cancer is gone, so everything is fine now, you should be happy and move on, because a lot of these things impact daily life on a regular basis. So from the bowel side, you should be very clear with your doctor about how often are you able to move your bowels and what the consistency is, and be as grossly descriptive as you possibly can be. We don't mind. We want to understand what you're able to evacuate. How easy is it to evacuate the stool, and also whether you're able to hold stool and sort of maintain continence. Is there any rectal or pelvic pain involved, both with defecation and otherwise? Are there any abdominal connected to this? Same thing goes for urinary function, and it's okay to bring this up at your GI visit, whether there's also concurrent urgency or issues with continence of urine, at bladder pain. And, sexual function has always been, pretty taboo to talk about, but shouldn't be. And it is part of life quality, and especially after gynecological surgeries could really be significantly impacted. Staci, next slide, please. So there is obviously once we've established some of these things, and, potentially some testing done, potentially not, medical management has some role. And generally from the medical perspective, there are definitely elements for bowel dysfunction that involve dietary modifications that could be useful, especially with the help of a gastro-specialized dietitian. Laxatives or antidiarrheals, depending on what somebody's issue may be, to sort of help streamline bowel function, which could help ease some of the pressure on the pelvis. Agents for gas relief for those who are kind of having a hard time with that for reasons related to their treatment, as well as often using neuromodulating meds to help control pain that could be related to nerve damage from all the treatments that have been received. Obviously I'm not a urologist, but I know that lifestyle and diet also play a role in urologic dysfunction. And there are various bladder spasm medications that are used as adjuncts. And, as far as sexual dysfunction goes, it's also, there's some limitations, because all there is sort of, agents for lubrication and hormonal agents in those patients where it is okay to be used. Next slide, Staci. Thank you, my slide advancer. So very, very importantly, pelvic floor, rehabilitation and therapy is actually part of routine postpartum care in a lot of, civilized countries of the world. And gynecological cancer treatment is infinitely more intense and pelvic health altering than, pregnancy and delivery. And in my opinion, the pelvic rehabilitation evaluation should really be part of routine gynecological cancer treatment. And I know that it's always not, because there's so many other things that are being focused on that seem like they're more important. And this is something that I think everybody should incorporate and sort of insist on. So, and now I'm gonna hand it over to Staci to kind of tell you all about what that care entails, what it can address, and what to expect at your visits.
Mm-hmm. Thank you. And just to put your last comment in a little bit more perspective, also, if you have a total knee replacement, you are immediately referred to physical therapy. If you have a rotator cuff repair, you're immediately referred to physical therapy. It is less common to be referred to physical therapy after having a pelvic surgery. And it's really frustrating that is the case, because it makes so much sense to me that if you have an orthopedic injury and an orthopedic surgery, you're immediately sent to PT. So why is that not the case when you have a gynecological bowel bladder prolapse surgery? Like, it should just be mainstream. And, Dr. Pashinsky and I are so passionate about doing these talks, because it really just helps spread awareness of what people should be asking of their doctors, and really advocate for yourself to not just settle for whatever symptoms that you're having post-surgery, and to really be proactive and go ask these questions and get help from a pelvic health PT who is very highly trained to be able to treat some of these symptoms and help you feel better.
Staci, I know that you're having a little issue with the volume. If it's possible, could you speak a little bit louder?
Yes, of course. I'm so sorry.
No, it's fine. Thank you.
We're gonna have Staci yell, get a megaphone.
I'm yelling. Okay, so urinary dysfunctions that pelvic health PT can treat.
Thank you.
Of course, urinary incontinence, So there are a couple of different types of urinary incontinence that you might see on your prescription that your urologist or doctor would write. SUI is stress urinary incontinence. So this is urinary incontinence that can happen when you cough, when you sneeze, when you laugh, when you go pick up something that's heavy. It is incontinence that happens when there's too much pressure on the pelvic floor and the pelvic floor isn't strong enough to block off the flow of urine. Urge incontinence, or UI, mainly happens when there is too strong of an urge to urinate and your body is not able to kind of block off the opening of the urethra to prevent leaking from happening. And mixed is when both can happen. Unfortunately, we see this a lot, but there are definitely things that we can do in PT to help remedy this. Overactive bladder, OAB, is more so when there is too much urgency or frequency, and the bladder is a little bit sensitive to how much urine is filling in it. And it basically gives you the signal that you have to go to the bathroom, even though your bladder is not full. The muscles can be involved in this as well. Nocturia is when you're getting up to go to the bathroom at night. Normal voiding at night, once you become over a certain age, is really just once a night. 2 is kind of pushing it. If you're getting up more than 2 times a night, there could be an issue with the pelvic floor muscles, but also the ability for your bladder to fully expand and hold the amount of urine that is normal. Burning, frequent urination, again, the muscles of the pelvic floor, sometimes when they are too tight and there's too much tone in them, they can give this sense of burning and frequent urination, even though it's not a UTI, even though your bladder can expand the way that it should. Sometimes the muscles can give you that sensation. And interstitial cystitis, sometimes this diagnosis can be given to you. Interstitial cystitis is actually where there are lesions in the bladder. Pelvic floor PT cannot do anything about the lesions, but again, the tightness, the tension, the pain that is associated with it, we can absolutely do stretches, mindfulness, breathing exercises, things to help calm the symptoms. We're trying to give the whole picture, just to be able to address the dysfunctions that can, we're not sure of what kind of cancer survivors are present in this population, so we really wanted to include everything that we possibly could to give you as much information as possible, but I can also slow down a little bit. And there will of course be
also guilty as charged. And I'm always told that I speak too fast and I don't realize it. So thank you for the feedback. As Jillian mentioned, this session is being recorded, so it will be available. I'm sure they will send you guys links to kind of be able to go through it at any pace that you wish. I think we've also done some more gastro-specific pelvic talks, which are actually available online that I could have Jillian send you guys links for, that, kind of also at your own pace without feeling pressured. Sometimes this feels a little overwhelming, so we totally get it.
There will also be a Q&A at the end. So if there are any specific questions that you have in particular, we're happy to answer those.
Thank you. Yeah. No, I mean, it's also, you're young. Things are faster when you're younger.
Okay. All right. So from the gastrointestinal dysfunction side, diagnoses pelvic PTs can help treat. One of the number one things that we see as a diagnosis on prescriptions from doctors is constipation outlet dysfunction. So basically what this means is that the pelvic floor muscles typically are too tight, they're not able to relax, and they're not able to coordinate with your body's urges to be able to evacuate stool completely. And a lot of times what people end up doing is they end up squeezing instead of bulging and pushing out, not because they want to, but because something has gone wrong in the wiring and the firing is not appropriate. And we need to re-coordinate the pelvic floor to be able to relax appropriately and the urge to be there so you are able to evacuate stool completely. This kind of goes along with the next diagnosis, which is incomplete emptying. So again, constipation outlet dysfunction, dyssynergia, incomplete emptying, all have to do with the inability to evacuate stool completely. Fecal incontinence is more so when you're leaking stool, when the muscles are not strong enough to close off the anus, close off the opening of the rectum, and you are leaking fecal matter. Gas incontinence, very similar. You're unable to hold. Gas incontinence is very similar. Either you're unable to detect when you have to release gas, or you're unable to hold back gas if you're in a place where you do not want to pass gas, those muscles are not strong enough to allow you to do so. Rectal pain or proctalgia, sometimes proctalgia is more of this like kind of stabbing rectal pain that doesn't necessarily come on for any reason necessarily. Rectal pain can be a result of post-operative pain depending on what operation you have had. Sometimes it can be referral pain from too much tension and too much tone in the pelvic floor muscles around the rectum. Levator-Ani syndrome, again, Levator-Ani is just a fancy name for all of the muscles in that deep pelvic floor layer. This may be a diagnosis that you see on your prescription, but it basically just means that the muscles in the pelvic floor are too tight and we need to get them to be able to relax. Abdominal bloating and distension is very common. It's something that we work with our patients often to help minimize. This can happen for so many reasons, and usually we are working very closely with a dietitian, a gastroenterologist, to find the cause of this. But from the musculoskeletal perspective, there are definitely areas within the abdominal wall, within the diaphragm, within the pelvic floor that, if not working efficiently, can add to abdominal distension and bloating. An abdominal phrenic dyssynergia is another incoordination of both your diaphragm and your abdominal wall to contract and relax appropriately. And there are a number of things that we can do in pelvic PT, which we'll go into a bit later for that diagnosis as well.
I'm not sure you're taking questions while you're talking, but I would love to insert a quick question, if that's possible, just about what you just said.
Sure.
I don't know.
Sure.
Yeah?
Yeah.
Okay, so I'm definitely going through what you just described,
Okay.
and I haven't been able to figure out what to do, but I made the appointment with the oncologist and they're doing all the tests, the scans, so to rule out whether the cancer came back. But I have this bulge and it's somewhat hard in my pelvis that, you know, I do have a belly, but now I have like this really tire thing that I never had before. And so am I barking up the wrong tree getting all these tests next week to rule out cancer when I should be, because I have such a poor digestive system and it's become worse, and chronic pain, all the things you described, and some of the bladder stuff. Should I just come to you guys and get some relief that way?
So I think I'll interject on this one, Staci, but I think that you should definitely proceed with all the testing, which could actually be quite useful for us as well. So for a gastroenterologist, very useful to have the cross-sectional imaging to be able to see exactly kind of what's behind that bulge. Is it gas? Is it stool? Is there anything else? And obviously ruling out a recurrence is incredibly important, especially with the malignancy that you're
yeah, I mean, it's only 2 months since I had a NED completely and good bloods, but I guess not to take up too much space, I would just say, I forgot what I was going to say. Okay, keep going.
But I think it's going through with the testing, and once you're given the clean bill of health from that side, then it's probably coming, to see a gastroenterologist if you have one, or and just to start working on the digestive side with all of that data. So
I have phenomenal gas, just phenomenal. I never had this in my life, so I'm pretty sure it's.
Yeah, we definitely. It sounds like you definitely need a GI involved and probably a pelvic PT, more than likely. But I think it's ruling that other part out is important.
Okay, and are the two of you in that category?
I'm the gastro and she's the pelvic floor rehab specialist. So
all right, yeah. I'm going to make an appointment. Thank you.
Of course. On to sexual dysfunction diagnoses. Dyspareunia is pain with intercourse. It's a fancy term for pain with intercourse. Vulvodynia is more of a burning or pain around the vulva and kind of the opening of the vagina. Vaginismus is basically a muscle spasm at the introitus, or the opening of the vagina, that people describe as an inability to allow anything into the vaginal canal, whether it's a finger, whether it's a tampon, whether it's your partner, whether it's a gynecological speculum, It literally feels like a wall and nothing is able to penetrate. Pain with erection, ejaculation, or orgasm. This can happen in both male and female patients. Obviously, we're focusing more on the female side of things today. But the inability to orgasm or pain with orgasm are definitely two things that could involve the muscle tissue of the pelvic floor. And pain with tampon use and our gynecological exams. Again, depending on the type of cancer and the type of treatments that have been used. When somebody has radiation to the pelvis, this can impact sexual function greatly. It kind of changes the tissue a little bit and makes it a little bit more fragile. And there are definitely things that we can do in physical therapy to help stretch the tissue very gently, very progressively, in coordination with working with your gynecologist and any appropriate creams, hormonal treatments based on your specific case alone. But these are some of the things that we definitely see on a regular basis that we can help with in physical therapy. And just pain in general. Every single cancer patient has been through so much, and whether it's a surgery, whether it's a period of immobility, whether it's you just haven't been able to exercise or walk, and your activities change and your tissue changes and your strength changes. There's so many secondary things that can happen as a result. Physical therapy is able to address mostly everything from the musculoskeletal perspective: lower back pain, pelvic pain, abdominal pain, SI joint dysfunction, which are those two joints kind of right in your back that attach your hip bones to your sacrum, hip or groin pain, dysmenorrhea, not so much for this patient population, but if you are a younger cancer survivor, if you are still having a period, it can be very painful, which is what dysmenorrhea is, painful periods. And endometriosis. We see a number of patients with endometriosis that are having a whole host of bladder, bowel, and sexual dysfunction symptoms. They then have their surgery to remove the endo, and we're working with them to, optimize their function after that surgery as well. Oncology-specific issues. So there can be a combination of what we've been discussing, a combination of bowel, bladder, and sexual dysfunction, depending on the treatments used to treat or eliminate bowel, uterine, bladder, vaginal, vulvar, or breast cancer. Like Dr. Pashinsky was saying, there's so many different things that happen during that life-saving treatment that are obviously so important. But some of the issues that patients are left with, they really shouldn't have to live with. Quality of life is a huge aspect of recovery as well. And finding a really good pelvic health PT who can address these issues with your oncologist, GI, urogyn, whoever it is, to optimize your function and pain levels is really very important. What we do in physical therapy specifically can be scar mobilization to whatever incisions or portals that you have. Scar tissue management, teaching you how to do some of these mobilizations at home so that the scar tissue doesn't adhere to any underlying tissue underneath it. A gradual return to exercise. A lot of times people will have restrictions after they have a surgery given by their surgeon, and we need to make sure that you are following those restrictions, but then also what is safe to return to in what time frame. You can't go from 0 to 60 after you've had a major surgery like this. There need to be steps in between to make sure that your mobility is correct and that you are activating the correct muscles so that you're protecting yourself and you don't injure yourself. Breast cancer treatment, surgery, rehab, I could do a whole other 2-hour talk on breast cancer rehab. But if you've had a mastectomy, a lumpectomy, a reconstruction, if you've had expanders, there are so many different things that go into that surgery. If you've had lymph nodes removed, you can have lymphedema. There are range of motion restrictions. There are weight limits that can happen that your surgeon recommends after you've had a surgery, and kind of rectifying some of the range of motion issues, the strength issues, and return to activity. A pelvic health physical therapist can absolutely help with post-op rehab for breast cancer. So what to expect during a pelvic floor PT evaluation? A number of people, who come in are like, yes, I've been to orthopedic physical therapy. I know what to expect as far as that goes, but what happens during a pelvic floor PT exam? At Zion Physical Therapy, We are a private PT-owned practice. We have both gym space, but we also have private treatment rooms, and all pelvic health PT evaluations and follow-up treatment sessions are performed in private treatment rooms with only your physical therapist. You are more than happy to have a chaperone, or we're more than happy to have you have a chaperone or family member. And then oftentimes we fully support that, just because you now have another set of ears that's going to help understand what we're asking you to do at home as far as a home exercise program, and they can sometimes participate in the therapy as well. First off, we are taking a full past medical history and a full surgical history, any medications that you're on, any other practitioners that you are seeing. We really want the whole story from start to finish, so we know where you are in your journey and we can help along the way. And what are your chief complaints and functional limitations? What are your goals? Is it to be able to be intimate with your partner again? Is it to be able to just go outside of the house and not have to map out where all the bathrooms are because you're afraid you're going to leak? Seeing how we need to tailor the physical therapy specifically to you and your goals and how you want to feel better. A posture assessment is something that we always do to make sure that you are appropriately stacking your head on top of your rib cage, on top of your pelvis, on top of your feet, just making sure that there are no faulty posturings that are contributing to your symptoms. An abdominal wall assessment, always with pelvic pain patients, lower back pain patients, but especially for patients who have had any kind of abdominal surgery or pelvic surgery. There can be holding patterns where you have too much tissue tension. There can be scars from incisions, from portals that we need to make sure are moving appropriately. So many different things that we will explain as we're doing an abdominal wall assessment. A pelvic floor exam, both externally and also optimally internally via either the vaginal canal and or rectal canal, to assess how these muscles are contracting, how they're relaxing, what their strength is like. Do you have a lot of like quick strength where you can hold it for 1 to 2 seconds and then it dies out? Or can you hold it for, 10 to 15 seconds? An example of why you would need this is if you are coughing, sneezing, and laughing and you're leaking urine, you need to be able to hold it, do a pelvic floor contraction, and squeeze while you're sneezing to be able to prevent leakage. An endurance example is if you're in Target, you walk in, you realize you need to go to the bathroom, and the bathroom is like a half a mile across the store. You need to be able to hold and contract those pelvic floor muscles to prevent leakage. So we're assessing both. We're assessing both power and strength, and also if there are any soft tissue restrictions present within the pelvic floor. Hip range of motion, flexibility, and strength measurements are also super important, just because they so closely insert to where the pelvic floor is that a lot of times if there's lack of strength or lack of flexibility in the hip musculature, it can influence the pelvic floor as well. And biofeedback is a tool that we'll get into in a little bit, which can be really helpful using either a vaginal or rectal sensor to be able to objectively measure what is happening with the pelvic floor muscles. Are they too tight? Are they too weak? And these are things that the biofeedback can help assist with from a visual perspective, instead of me just saying you are tight or you are weak. So how is pelvic floor dysfunction treated? Treatment is based on the results of a thorough evaluation of how the pelvic floor muscles function. So I'm going to go through a list of all the things that we can do in physical therapy. Not everything is appropriate for every single patient, but based on your history, based on your presentation, and based on your impairments and functional limitations that we find, that's how I create a plan of care that is specific to you. So some of these things might involve, some may not, but just to give you the full scope of what we are able to do in a pelvic floor physical therapy session, I'm going to run through some of these things. So manual therapy at Zion Physical Therapy, we are one-on-one for 45 minutes. So that means that I have 45 minutes with the patient. There are no aides, there are no PTAs, there's nobody interrupting us. And I am really able to do a lot of manual therapy that's targeted to release any tissue musculature that's tight, and trigger points both externally and internally, whether it's the vaginal canal, whether it's the rectal canal. We determine that upon evaluation. We do a lot of neuromuscular re-education, which is basically retraining the muscles to be able to contract, to be able to relax, and then to be able to bulge or like stretch a little bit more appropriately to make sure that you have full function of these muscles. Stretching and strengthening within the session, whether I'm doing it to a patient or we're teaching you stretching and strengthening to do on your own at home. Biofeedback, again, I'll get into that a little bit later. Dilator therapy, again, I'll get into that later. Same with anal rectal balloon retraining. Home exercise program is super, super important. If you're in physical therapy once a week for 45 minutes, I am giving you all the tools to help yourself. And then we really, really encourage follow-up with a home exercise program at home, whether it's stretching, strengthening, using some of these tools that we're mentioning to really create lasting changes. Posture education and modification. Sometimes we use taping techniques to enhance mobility or stability. And then collaboration with your other healthcare providers, especially your GI, your nutritionist, your acupuncturist, your OBGYN, urologist, pain management, anyone you're seeing in relation to your cancer care. Again, we are a very low volume clinic, which means that we don't treat a ton of patients, and we really do have a lot of time to coordinate care with your referring providers and make sure that we're doing everything appropriate within our scope of practice. So manual therapy, what to expect during the sessions? Sometimes it can involve abdominal or colonic massage. Colonic massage is basically a way to kind of massage your large intestine to be able to promote peristalsis, which is the ability for gas and stool to kind of move through your system at an appropriate rate. Diaphragm release. Sometimes the diaphragm or that upper core muscle can be tight, which can lead to some of the gas and bloating and distension issues. External myofascial and or trigger point release to the pelvic floor, to the lumbar spine musculature, and to the hip musculature. Internal soft tissue releases to both all three layers, superficial and deep musculature via the vaginal or the rectal canal. During the examination, typically if somebody's coming in with either sexual dysfunction complaints or bladder complaints, we'll do all of the assessment and treatment via the vaginal canal. If somebody's coming in for more of that abdominal bloating, constipation, incomplete emptying, rectal pain, we'll assess and treat via the rectal canal. Manual stretching to both of the hips, again, to make sure that everything kind of surrounding the pelvis and the pelvic floor is flexible, and joint mobilization, if necessary, to the hips, lumbar spine, coccyx, sacrum, SI joints. Again, everything is tailored to your specific body and symptoms. Dilator therapy and pelvic wand. So dilator therapy and pelvic wands can be very, very helpful for patients who have either had pelvic surgery to eliminate uterine cancer, vulvar cancer, vaginal cancer. Also with patients who are prenatal postpartum, but what they help do is stretch the vaginal or rectal opening and canal. And there you can see in this top picture, they are graded circumferentially. So they start off as like something super tiny, like as the circumference of my pinky, and they go all the way up to about, I think the biggest one is about 1.5 inches circumferentially. And it's a great way to help stretch. Most of the time we use this for the vaginal canal to stretch the tissue around the vaginal canal. Pelvic wand is very similar. This sometimes is used to stretch more of the internal muscle tissue. And again, based on your examination with a pelvic health PT, we'll determine which of these is appropriate, if they're appropriate for you. And this is a great tool to use both in office, but also as part of your home exercise program at home. And we are able to give you specific frequency, duration. I'll email you like the link of which one to get if it's appropriate. Biofeedback and NMES. So these can be used for any of this dysfunctions: pelvic pain, sexual dysfunction, bowel dysfunction, urinary dysfunction. We use a pathway MR15, and I'm realizing I left them in the other room. I had them to show you, but they're used to assign objective measurements to pelvic floor tone. So if I do an exam via the rectal canal and I'm like, oh, okay, there's definitely increased tone, increased tension in these pelvic floor muscles. Using this machine, we use an internal rectal sensor and we hook it up to the machine, and it gives you a numeric output with norms to say, okay, yes, this is your normal resting tone is 3.0 and you're resting at an 8. Let's try to get that number down. Or you are weak you're resting at a 2.0, and we need to give you a goal of getting up to a 10.0 when you're trying to do strengthening. It assessed both resting activity level of the pelvic floor in addition to strength in relation to power and endurance. So basically we create a home exercise program based on your numbers with the biofeedback machine. It's used both with exercise to increase tone when you have weakness and also to relax tone when you have too much tension. Neuromuscular electrical stimulation, we use a different machine for this, and it is used to basically help to elicit muscle contraction and to aid in proper facilitation of the pelvic floor. So a lot of times I'll get patients who come in and I'm like, okay, do a pelvic floor squeeze, do a Kegel, and they cannot elicit that contraction. Whether it's due to decreased sensation, whether it's just due to decreased strength or awareness, sometimes using this machine with an internal, either rectal or vaginal sensor, whichever is appropriate, it helps give a little bit of an impulse to the muscle tissue and helps you kind of find where those muscles are and how to squeeze and recruit those muscles so that we can then progress with strengthening appropriately. These machines can be used both in office, but there are also home biofeedback and NMES machines that we can absolutely set somebody up with to do a couple times a week to just promote quicker progress. Anal rectal balloon retraining, this is really used more for the GI patients to retrain proper sensation and urge. It uses a small balloon, which is attached to a tube and a syringe, and we inflate it with either air or water. And there are different norms that we're looking for as far as when one should feel the urge to defecate or the sensation of the balloon, and we help this to retrain bowel function. We definitely don't use this for everyone, but it is a very, very helpful tool for those that it is appropriate with. And again, it can be used in home and in office. Exercise and home exercise program. We do a ton of this, specific exercises and strengthening exercises, different aerobic and endurance activities based on your goals, a return to sport or activity, use of the dilators, pelvic one, biofeedback, NMES, anything that is appropriate for your specific symptoms. We can certainly tailor a program to be appropriate in office, but also something for you to kind of keep up with compliance at home. And compliance is so very important. I ask about it at every single session. Again, if you're only in the office here with me 1 or 2 times a week, you really need to be reinforcing some of these strategies on your own at home. Just some other populations that we definitely see a lot in pelvic floor PT, the prenatal postpartum population. I'm not sure if anyone on this talk is of childbearing age, but we do see a number of patients with pelvic pain or symphysis pubis dysfunction, which is that pubic bone in the front. Sometimes it gets irritated or stretched a little bit. It can create a lot of pain with walking, with sit to stand. Diastasis rectus abdominis, DRA, is basically a separation of the abdominal muscles where the connective tissue gets stretched, and it can create some bloating, distension, some abdominal pain, and an inability to kind of return to doing what people want to be doing. Core weakness, return to activity, lower back pain, any prolapse that happens after delivery, and then also episiotomy and C-section scar management. So just an aside as to other patient populations that we see.
And also, Staci, I mean, just, in terms of even the population, the patients that we're talking to right now, a lot of patients obviously have had already pelvic trauma from the time that they had kids. C-sections, episiotomies used to be very in vogue and kind of part of routine deliveries, and nobody got PT. And then on top of it, there's the insult of pelvic cancer and treatment. And then obviously anybody who has a daughter, has grandkids, this should be a spread the word kind of scenario for that.
Absolutely. Like Dr. Pashinsky was saying before, there is routine referrals to pelvic health PTs at the 6-week follow-up visit after one has either a vaginal delivery or C-section, just to make sure that there are no issues that need to be resolved before one kind of goes on with their activities of daily living. It is my goal to have that kind of be the case here as well. So definitely just something to make note of is what we can help with as well. To Kegel or not to Kegel, this was a whole topic of conversation that Dr. Pashinsky and I did a whole other lecture on that is available via her website. But I get this question all the time. When should I be doing Kegels? When should I not be doing Kegels? A Kegel or a pelvic floor contraction is what we call up training. It's geared to improve strength and endurance. When should I be doing Kegels? When you have confirmed weakness and or laxity in the pelvic floor muscles that are causing symptoms. Conversely, reverse Kegels or bulging or down training is exaggerated relaxation geared to decrease tone, to decrease pain, and to decrease overactivity. When should you be doing these? When you have confirmed hypertonicity and tightness of the pelvic floor causing symptoms. How do you know what's right for you? Be evaluated by your doctor and a pelvic health PT. A lot of times we can assume what's happening with certain diagnoses and certain presentations, but until we actually do an evaluation, it sometimes is hard to just give you that information and to prescribe specific exercises without having been appropriately evaluated. We'll then be able to.
And it's all about teamwork, Staci, right? So it's all about, having your various doctors coordinate and work together. So this involves your surgical team, your oncologic team, your gastro, your pelvic rehab person, your gynecologist. This is all, it takes a village to get somebody into recovery, and the hard work that you guys have all done with surgery, chemotherapy, radiation, it's us kind of coming together to clean up the after effects.
Absolutely. And we'll, everybody on your team will be able to prescribe appropriate medications, therapies, exercises tailored to you specifically.